各位观众朋友们，晚上好！欢迎大家来到本期全血化学发光系列讲堂，全血心肌标志物性能验证与中医临床应用对话。本次学术直播主持的是刘向一教授。下面请允许我简单介绍刘向一教授。刘向一，医学博士、教授、博士生导师，首都医科大学附属北京同仁医院检验科主任，安德森肿瘤中心访问学者。他的研究方向有生物标志物的筛选及应用、实验室管理和方法标准化。他主持和参与多项国家级、省部级课题，参编“13·5”“14·5”规划教材多部，主持参与国家或行业标准18余项，北京市卫生系统高层次骨干人才等。他的主要兼职有 ISO 212 WG1 成员、IFCC THGLQ 通信会员、中国健康管理协会检验医学分会会长、CNAS 评定委员会委员和医学实验室主任评审员，国家药监局审评专家，中华医学会检验分会生化学组委员兼秘书，中国医院协会临床检验分会常委，首都医科大学检验学系副主任等。下面让我们有请刘教授。
尊敬的各位专家同仁，线上参会的海内外朋友们，大家晚上好！欢迎大家来参加我们全血化学发光的系列直播第2期啊。这次讲堂的一个主要内容呢，就是全血心肌标志物性能验证和中医临床应用的对话。实际上，我们都知道，在心血管标志物里，肌钙蛋白一直是我们心血管疾病的一个诊疗的一个前锋。它对于心脑血管疾病，尤其是心血管疾病的一个诊断、治疗以及预后评估都至关重要。同时呢，我们也知道全血检测技术呢，在它的发展到今天，快速便捷，而且极大的也提升了它的灵敏度，正逐步在我们的临床检验和危重急症领域发挥它重要的作用。实际上，在我们当前的临床实践和技术发展中，我们特别关心以下几个问题。首先，就是全血的心肌标志物，它的性能，我们更关注哪些的考量？同时呢，放眼海外，它的检测在我们意大利的医院是如何应用的？它背后也有哪些考量和思考？同时，中意两国在我们心血管疾病的一些诊疗路径和全血标志物的一个应用策略上也有哪些差异，以及这项技术未来的走向，它是否将在我们临床应用中展现出更广阔的前景。今天晚上，我们非常荣幸的邀请到2位专家学者，来围绕我们全血的心肌标志物的性能验证以及它的临床应用展开深入的讨论和对话。首先，第一部分，我们邀请到意大利马尔凯理工大学的 Professor杰克布他这个稍微有点Jacopo 教授，他长期致力于心血管疾病的一个生物标志物的研究工作。他的授课题目呢是全血心肌标志物的性能验证与意大利院内的应用思考。首先，我们来介绍一下 Jacopo 教授。他是马尔凯理工大学病理学的教授，也是意大利国家老龄研究中心老龄研究和护理中心的临床学者，在中心实验室和精准医学诊疗部开展工作。他的研究方向呢，聚焦于衰老的分子机制，核心方向包括免疫衰老、心血管疾病的生物标志物以及内皮功能障碍和衰弱综合征。他主持了由国家资助的重点研究课题，并积极的参与针对衰老相关性疾病的跨学科的一个合作研究计划。现在有请雅各布教授授课。Let's now welcome Professor Jacopo to share with us. Professor, please.
Hello, good evening to everyone joining us today. I would like to thank RealMind for the invitation and for the opportunity to share our experience on the validation of whole blood cardiac biomarkers and their practical application in hospital settings. My name is Jacopo Sabbatinelli. I am an associate professor at Università Politecnica delle Marche, and I work at the Clinic and of Laboratory and Precision Medicine at the Research Hospital IRCA in Ancona, Italy. Today, I will focus on the evolution of rapid cardiac diagnostics, the challenges faced by laboratories, and how hybrid solutions such as the RealMind MCL60 may help bridge the gap between analytical quality and clinical speed. Let's start from the clinical scenario. Around 10% of all emergency department consultations involve patients with suspected acute myocardial infarction. Myocardial infarction is a common and potentially life-threatening condition, and the message we all know very well is that time is muscle. Rapid diagnosis and rapid treatment are absolutely critical. At the same time, rapid rollout has enormous clinical and economic relevance. Most patients presenting with acute chest pain do not have an acute myocardial infarction. Identifying alternative causes early allows safe discharge from the emergency department or outpatient management, reducing overcrowding and unnecessary admissions. This approach is grounded in the fourth universal definition of myocardial infarction. Here, myocardial infarction is defined by evidence of myocardial injury detected by elevated high-sensitivity cardiac troponin values in the appropriate clinical context. High-sensitivity troponins have fundamentally changed how we diagnose myocardial infarction, allowing detection of very small changes at very low concentrations. This slide reminds us of a critical concept. Elevated troponin does not automatically mean myocardial infarction. Troponin elevation reflects myocardial injury, which may occur in many conditions, such as anemia, hypoxemia, renal disease, tachyarrhythmias, or heart failure. This is why laboratory results must always be interpreted together with clinical presentation, ECG findings, and imaging. The most recent ESC guidelines from 2023 strongly emphasize the use of structured diagnostic pathways, integrating clinical assessment, ECG, imaging, and laboratory biomarkers. A key point highlighted by the guidelines is the different diagnostic role of high-sensitivity cardiac troponins across the ACS spectrum. In non-ST elevation acute coronary syndromes, high-sensitivity troponins play a central role in differential diagnosis, allowing clinicians to distinguish between NSTEMI, where myocardial necrosis is present, and unstable angina, where troponin concentration remains below the diagnostic threshold. In this setting, both absolute troponin values and dynamic changes over time are essential, and high-sensitivity assays provide the analytical resolution required to support this distinction safely and early. In contrast, in patients presenting with the ST elevation myocardial infarction, the diagnostic pathway is fundamentally different. Here, the diagnosis is primarily driven by clinical presentation and ECG findings, and immediate reperfusion therapy should never be delayed while waiting for biomarker results. In ST elevation myocardial infarction, troponin measurements remain useful for confirming myocardial injury, estimating infarct size, and prognostic stratification, but it is not the determinant of the initial clinical decision. Overall, the ESC guidelines clearly position high-sensitivity troponins as indispensable in the diagnostic workup of non-ST ACS, while recognizing that their role in ST elevation myocardial infarction is complementary rather than decisive. In addition to defining when and how troponins should be used, the 2023 ESC guidelines for the management of non-ST ACS provide a very clear operational framework based on the ESC 0-1 hour and 0-2 hour algorithms. These algorithms rely on assay-specific cutoff values, which apply not only to central laboratory assays, but also to validated point-of-care and near-patient testing systems. The cutoffs are defined both in absolute terms, using troponin concentrations at presentation, and in terms of delta changes over time, relative to the baseline value at 1 or 2 hours. Using the ESC 0-1 hour and 0-2 hour algorithms, patients are stratified into 3 main clinical pathways. Patients with troponin values below the rule-out threshold and without significant dynamic changes can be safely discharged. Patients with troponin concentration above the rule-in cutoffs or showing clear dynamic increases are classified as non-STEMI and should receive appropriate treatment. Finally, patients falling into an intermediate zone are assigned to an observed pathway, with continued clinical surveillance and additional testing. This structured, time-based, and assay-specific approach enables rapid, safe, and reproducible decision-making, while emphasizing the need to use only assays that have been properly validated for these ESC algorithms. However, the guidelines clearly outline several important caveats. First, these algorithms must always be used together with all available clinical information, including chest pain characteristics and ECG findings. Second, they should only be applied to patients with suspected acute coronary syndrome, not to unselected emergency department populations. Third, although the algorithms apply regardless of symptom onset, in very early presenters, an additional troponin measures, for example at 3 hours, may be needed. Further caveats include the possibility of late troponin rises, which occur in a small but relevant proportion of patients. Serial testing should therefore continue while clinical suspicion remains high. Another key message is that time to decision equals blood flow plus turnaround time, TAT. The ESC algorithms refer to sampling times, not to when results become available. Finally, and this is crucial for laboratories, the algorithms are assay-specific and must be only used with validated methods. From the laboratory perspective, high-sensitivity troponins have reduced diagnostic times dramatically, from 6 to 12 hours down to less than 3 hours. But this creates new challenges. Centralized laboratories often struggle with sample transport, pre-analytical processing, and the need for turnaround times below 60 minutes, especially in busy departments. This has driven interest in near-patient and point-of-care solutions that can deliver high-quality results faster. This figure illustrates the difference between centralized laboratory testing and near-patient testing, even with point-of-care testing. With central laboratories, the total process from blood draw to clinical decision may take around 1 hour or even more with a high human-dependent factor. Near-patient testing has the potential to reduce this dramatically, sometimes to just 15 minutes, which can have a major impact on patient flow and outcomes, albeit in most cases at a higher cost. The traditional point-of-care platforms often use whole blood, but this introduces analytical challenges. Hematocrit effects, viscosity, and pre-analytical interferences can affect accuracy and precision. Central laboratories offer better analytical performance, but require serum on plasma and a full pre-analytical phase. What we may need are hybrid instruments, systems that can work with whole blood and also serum and plasma, while maintaining analytical quality comparable to core laboratory analyzers. This brings me to the RealMind and CL60 that we had the opportunity to evaluate. It is a fully automated chemiluminescence immunoassay analyzer using direct chemiluminescence technology with acridinium ester labeling. It delivers the first results in about 13 minutes after sample loading, with a throughput of up to 144 tests per hour and a very compact footprint. It is a desk instrument, benchtop instrument. Importantly, it supports multiple sample types, including whole blood and capillary blood, using the same reagent, so without dedicated reagents and calibration curves for different sample matrices. In addition, samples with different matrices, such as serum and whole blood, can be processed simultaneously, even for the same analyte or for different analytes, without interrupting the workflow. This flexibility is particularly available in emergency and also in small laboratory settings where sample times and clinical priorities may vary. From an operational point of view, the system includes up to 192 onboard disposable reaction cuvettes that can be loaded continuously without flow interaction. These features so support an uninterrupted workflow, which is essential in emergency and decentralized settings. This slide shows the reagent architecture. The system uses streptavidin-coated magnetic particles, acridinium ester labeled antibodies or antigens, depending on the test, and biotin labeled antibodies or antigens. All assays are based on a master calibration curve, meaning that only two calibrators, or more appropriately adjusted, are required to adjust and align the calibration during routine operation. In addition, two quality controls are provided for each test, set at clinically relevant concentrations, allowing continuous monitoring of analytical performance in the most meaningful decision ranges. A key innovation is the integrated hematocrit module. For each sample, the system measures hematocrit and automatically calibrates whole blood or capillary blood results in real time. This is critical to reducing variability and to improve comparability with serum or plasma measurements, as it may happen in different settings. Now we move to the core of the analytical evaluation, starting with high-sensitivity cardiac troponin T measured in serum. This assessment was conducted strictly according to the CLSI recommendations, specifically EP17 for analytical sensitivity and EP5 for imprecision. The study population was intentionally broad. We included more than 1,000 healthy blood donors, as well as a subgroup of healthy older outpatients from our hospital, with ages extended up to 92 years and without known cardiovascular disease, together with patients admitted to cardiology wards or to the emergency department. Including this older outpatient population is particularly valuable because identifying truly cardiovascular healthy elderly individual is increasingly difficult, yet essential for defining realistic reference distribution, which take into account also the extreme ages. This design allowed us to assess both analytical robustness and clinical plausibility across a wide spectrum of age and cardiovascular risk profiles. From a methodological point of view, the assay is a double antibody sandwich chemiluminescence assay using acridinium ester labeling, with a relatively small sample volume and a wide linear range, extending up to very high concentrations. Let us now focus on analytical sensitivity and precision. The limit of blank was extremely low, and the calculated limit of detection was 0.70 nanograms per liter, which clearly places this assay within the high sensitivity category. Equally important for the high sensitivity requirements is the functional sensitivity. The limit of quantification at 10% coefficient of variation was just over 4 nanograms per liter and reached 1.2 nanograms per liter at a 20% CV, which is particularly relevant for early rule-out strategies. If we look at the imprecision profile, total imprecision remained low and stable across clinically meaningful concentrations, including the low range close to the 99th percentile. This level of precision is essential if we want to apply the ESC rapid algorithms safely. Here we examine the distribution of troponin values in the reference population. Median concentrations were low as expected, and we observed a clear sex-specific difference with higher values in males compared to females. Importantly, the derived 99th percentiles were fully consistent with what has been reported for other similar high sensitivity assays. In addition, we confirmed the well-known age-related trajectory of high-sensitivity troponin, with concentrations progressively increasing with age, even in apparently healthy individuals. These findings further supports the emerging role of high-sensitivity troponin not only as an acute diagnostic biomarker, but also as a marker of cardiac aging and cardiovascular risk stratification. Method comparison was performed against the Roche Elexis high-sensitivity troponin T assay, which is widely considered a reference standard. The correlation was excellent, with a Pearson coefficient close to 1. When focusing on the most clinically relevant range, so that is below 100 nanograms per liter, the observed bias was small and well within acceptable limits. This is particularly important because most clinical decisions in the emergency department occur exactly in this low to intermediate concentration range. We then moved from serum to whole blood, which represents one of the most challenging but also most clinical attractive scenarios. Whole blood testing introduces variability related to hematocrit, viscosity, cellular components, and tube of sample collection. Despite this, the assay maintained a limit of detection of 1.5 nanograms per liter and the limit of quantification at 10% CV of 3 nanograms per liter. These values are remarkably close and even better in the case of limit of quantification to those obtained in serum, and confirm that the analytical sensitivity is preserved also for this different type of matrix. The imprecision profile in whole blood remains stable across concentrations. This finding is particularly relevant because variability at low troponin levels can directly affect patient classification in rapid diagnostic algorithms. The integrated hematocrit correction plays a key role here, reducing systematic bias and improving comparability with plasma or serum-based measurements. We then assess the 99th percentile in whole blood, and this is in its concordance with the reference plasma method. Sex-specific percentiles were preserved, and overall clinical agreement of positivity based on the 99th percentile was extremely high. The kappa coefficient indeed clearly indicates excellent agreement beyond chance, supporting the clinical interchangeability of whole blood and plasma measurements. When focusing on the low measurement range, which is the most critical for rollout strategies, passing Bablock regression analysis showed an excellent agreement with the Roche reference method. The slope was close to unity and the intercept was minimal, indicating the absence of significant proportional or constant bias. This confirms that whole blood high sensitivity troponin T measurements obtained with the MCL60 are analytically comparable to serum-based measurements based on the Roche assay. We then explored the preliminary data on high-sensitivity cardiac troponin I in whole blood. This evaluation was conducted in 33 patients presenting to the emergency department of an Italian hospital with acute chest pain, which is exactly the clinical setting in which the ESC guidelines recommend the application of rapid diagnostic algorithms. Although the evaluation is still ongoing, early results are encouraging. Analytical characteristics were consistent with high sensitivity requirements, and the assay demonstrated good linearity across a wide concentration range. Importantly, the results obtained on the MCL60 were directly compared with the reference method used in the hospital central laboratory. So this was our primary objective. The method comparison between MCL60 and the central laboratory showed strong correlation with the reference method. While some positive bias was observed at higher concentrations, clinical agreement at the 99th percentile reached 97%, which was a very relevant endpoint. This data suggests that also high sensitivity cardiac troponin I whole blood testing may become a reliable option in near patient settings. Moving beyond acute coronary syndromes, we evaluated also NT-proBNP, that is the cornerstone biomarker for heart failure. Both serum and whole blood samples were included in this multi-center evaluation, reflecting real-world conditions from both emergency department and outpatient facilities. The assay has a declared appropriate analytical sensitivity, precision, and a wide linear range suitable for both acute and chronic heart failure assessment. Limits of detection and quantification were well below clinically relevant threshold. Imprecision remained low across the concentration range, including values close to commonly used decision cutoffs, such as the 125 nanograms per liter threshold used for heart failure rule-out in non-acute setting, the so-called dry NT-proBNP. This level of analytical stability is crucial for monitoring, longitudinal assessment, and cardiovascular risk stratification. Method comparison against both Roche Lexis and radiometer AQT90 showed excellent correlation for serum and whole blood, respectively. This confirms that results generated by the MCL60 are fully comparable to established laboratory and point-of-care system. Finally, we evaluated D-dimer, the end byproduct of the coagulation and fibrinolysis process in whole blood. D-dimer is a biomarker with broad application in emergency medicine. Correlation with the reference radiometer AQT90 platform was strong, with high Pearson coefficient, correlation coefficients, and clinically acceptable bias. Importantly, D-dimer completes the whole blood biomarker panel, allowing a more comprehensive assessment of acute chest pain and dyspnea in the emergency setting, particularly in the differential diagnosis of thromboembolic conditions. These data further support the versatility of the system beyond purely cardiac biomarkers. Before concluding, I would like to briefly mention a poster that we recently presented at the recent Italian Immunometry and Immunoassay Conference. In that work, we showed that interleukin-2 and interleukin-8 measured in direct chemiluminescence on the MCL60 platform are able to predict long-term mortality in hospitalized geriatric patients with history of cardiovascular disease, with also a very good analytical performance. For those interested in the analytical details and the full clinical results that are in publication, the QR code in this slide provides direct access to the online poster. Our results suggest that the same system can support not only cardiac biomarkers and emergency-related diagnosis, but also routine immune and prognostic markers in complex patients. In conclusion, the MCL60 is a true hybrid instrument, combining operational speed with high analytical quality. It shows a good agreement with reference methods for multiple biomarkers in both serum and whole blood. Biases are limited and clinically acceptable, particularly in the decision-making ranges. The system performs effectively in both central laboratories and decentralized settings, supporting rapid diagnostic pathways, and most notably, it is intuitive and easy to use, also for non-dedicated laboratory personnel. Thank you very much for your attention. I look forward to all of your questions and the discussion.
Thank you very much, Professor Jacopo, for such a detailed presentation. Very, very interesting. And 非常感谢Jacopo 教授为我们带来的一个非常精彩的一个性能验证的分享。实际上就是说，对于我们这一台新的一个全血发光仪呢，它也做了一个非常严格的一个性能验证实际上它从我们现在急诊胸痛的这个临床的指征去出发，然后结合了我们现在的一个2023的一个 ESA 的一个指南，然后把这些痛点结合我们的性能验证做了一逐一展示。实际上它在性能验证里呢，实际上跟我们理解还是比较一致的其实上严格去做了 LB 就是空白线，然后 LOD 减除线， LOQ 就是一个定量减除线，以及还有一个方法学的比较大部分是跟罗氏进行了比较，还有一部分是跟那个就是血气那厂家叫什么雷度进行了比较。实际上它得的结果我觉得都是非常精彩因为实际上第一个我们达到了一个实现，因为我们从现在1小时、2小时的一个胸痛的指南，它做到了一个完美。第二个呢，性能可以跟我们现在的一个声称的高敏都做了一个严格的匹配。同时我们也看到它做了一个男女的一个99%的一个诊疗线I 和 T 都进行了展示。同时呢，也对我们的 NT-proBNP 实际上他也讲到了我们还可以做第二具体，还有一些血栓4项在这个小机上就做了一个完美的展示。实际上对于我们来说嘛，就是杰克布教授分享这些全血性能标志物的一个系统，更让我们体现到了全血一体机这个对我们临床能够改善我们心血管的急诊的诊疗流程中可以作为一个有巨大潜力的一个快速检测技术。那实际上呢，今天的分享呢，实际上它也在最后一个幻灯展示了去可以进行扫描，进行共享和展示我们也最后呢再次感谢杰克教授对我们的精彩分享。如果还有什么疑问，我们也可以后台去展示。下面呢，实际上我们进入我们的一个第二个环节，是讨论环节。那这个讨论环节呢，我们也邀请到了我们朝阳医院张瑞教授。那这个环节呢，我们就来讨论，在我们全血心肌标志物经过严谨的验证以后，在中国和意大利这种不同的背景下，会有哪些不同的应用？那这些问题呢，我们就邀请到了已经来到我们现场的特邀嘉宾张瑞教授，他也是我们美国霍金斯医院访问学者。实际上，在上一个全血化学发光系列讲座中，他作为我们中方也分享了我们全血高敏肌钙蛋白的一个性能验证也得到大家一致的好评。接下来呢，我简单介绍一下张瑞教授。咱们界面有他的中文展示吗？因为这边好像没有给到我他的一个简历。如果没有呢，实际上我们也知道张瑞教授是目前应该也是博士生导师，是我们朝阳医院首都医科大学附属朝阳医院检验科的副主任一直治理我们各种标志物的一个标准化。他在这个工作中比较突出，同时也获得了很多国家级的奖项，也有好多重要的社会兼职，也发表了很多高水平的论文。那下面呢，我们欢迎张教授和我们的意大利的教授一起来讨论那个全血心肌标志物的临床应用以及它的一个前景展望有请张教授。
非常感谢向一主任的介绍，大家晚上好，也非常感谢Jacopo教授分享的一个精彩报告，我们确实也学到了很多。首先呢，在这里呢，我想在这讨论环节呢，我首先呢有一个比较好奇的问题，Jacopo教授，那么我们注意到您 PPT 的研究计划中呢，是纳入了33例因为胸痛就诊于急诊科的患者样本。主要用于呢高镁肌酐蛋白的一个相关研究。那么我想请问，能否请您呢为我们介绍一下，这项研究的主要假设和探索的方向是什么？Good evening, everyone. Thank you so much, Professor Jacopo, for this fantastic presentation. Your insights into the validation and clinical practice of the whole blood chest panel, and backed by real-world data from Italy, are truly eye-opening. We have gained a great deal. And now I have a question out of curiosity. Professor Jacopo, we noticed that your slides, your research plan involves samples of 33 patients admitted to the emergency department due to chest pain for a study on high sensitivity CTN. Could you share with us the main hypothesis and exploratory direction of this research? Thank you.
Thank you for your question. This study in 33 emergency department patients with chest pain is designed as a pilot method comparison and feasibility study rather than a clinical outcome study. Our main hypothesis was that whole blood high sensitivity troponin I testing performed on a compact chemiluminescence platform can provide clinically interpretable results compared to serum measurements, while being suitable for early use in the emergency setting. From an exploratory point of view, we aim to assess analytical comparability, the practical impact of using whole blood, and importantly, the ease of use and workflow integration as a point of care or near point of care solution in the real emergency department conditions. Overall, our goal was to test feasibility, robustness, and most notably usability by non-laboratory personnel as a prerequisite for larger prospective studies focused on rapid chest pain evaluation.
谢谢，感谢您的分享，亚鹏教授。我们很期待您未来的研究。那么我们参考呢欧洲心脏病学会那么最新的关于 ACS 一个管理的指南的一个推荐。那么针对于 ACS 患者，建议采用01小时和02小时这种快速排除的路径呢，也想再继续请您分享一下。在意大利的临床实践中，这种路径呢，在院内急诊中我们是如何应用的？另外呢，在实践中，如果我们是不是有遇到哪些具体的挑战吗？Thanks for your sharing, Professor Jacopo. We look forward to your further research. With reference to the recommendations outlined in the latest 2023 European Society of Cardiology guidelines for the management of acute coronary syndrome, ACS, which advocate for the 01 hour and 02 hour and the rapid rule-out pathways for acute coronary syndromes. These patients. And Professor Jacopo, could you please share how these pathways are applied in hospital emergency departments with in the context of Italian clinical practice, and what specific challenge have you encountered during the implementation? Thank you.
This is a very insightful question because we all know that not often, often the guidelines do not correspond to the reality, but this is not quite the case for these specific guidelines of the European Society of Cardiology. In Italy, the implementation of the 0-1 hour and 0-2 hour rapid rollout pathways recommended by the ESC is indeed very well established in hospital emergency departments, but it is applied with a degree of organizational flexibility based also on the clinical aspects. The overall structure of the pathway is fully aligned with the guidelines, with early ECG and high sensitivity troponin testing at presentation and serial measurements at 1 or 2 hours, with the choice between the two algorithms depending on local analytical availability, so laboratory testing, and workflow capacity. In an healthcare system like the Italian one, which is increasingly being centralized, these pathways are particularly valuable because they allow independent clinical decision to be made without duplicating full laboratory infrastructure. In this context, near-patient or point-of-care testing plays an important supportive role in ensuring compliance with rapid algorithms while limiting additional human resource consumption. The main challenges encountered are related to regional heterogeneity in resources, with uneven access to high-sensitivity assays and advanced imaging, workforce limitation in busy emergency departments, and the management of elderly or very clinically complex patients in whom baseline troponin values and dynamic changes over time can be very difficult to interpret. In addition, differences between assay-specific cutoffs and a natural degree of clinical caution sometimes reduce the efficiency gains expected from rapid rollout strategies. Overall, while the ESC pathways may provide a robust and effective framework, their real-world implementation in Italy requires continuous balancing between standardization, clinical judgment, and most notably, economical and organizational sustainability. So this was the brief overview of how this diagnostic strategy is clinically applied in Italy. There, Professor Zhang, could you share the corresponding diagnosis and treatment pathways and patient management models for in-hospital emergency departments that apply in China?
Oh, thank you for the question, Professor Jacopo. Consistent with the logic of stratified patient management in Italy, we also categorize patients into low, medium, and high risk levels. And unlike the regional difference in Italy, the results gaps in China are primarily reflected in the urban-rural divide. And tertiary hospitals have already reached internationally advanced standards in terms of equipment and diagnostic and therapeutic capabilities. While primary care hospitals in vast rural areas still face the low penetration rates for the high sensitive CTN testing equipment. And furthermore, the implementation and coordination of tiered healthcare systems require refinement, as there remains a widespread tendency in China for patients to seek treatment at large hospitals. And in China, the core of the in-hospital emergency diagnosis and treatment pathway for acute coronary syndrome lies in taking the construction of chest pain centers as a key starting point. And hospitals in the major Chinese cities, such as Beijing, Shanghai, and Guangzhou, have already implemented the practice of rapid stratified diagnosis and treatment pathways for ACIs patients. And in particular, Chinese hospitals have established dedicated green channels, including chest pain centers, all the cardiac centers, and coronary care units. We call it CCU, to alternate resources across the various clinical departments and provide rapid treatment. Additionally, the administrative guidelines for Chinese chest the pain centers set strict time windows for the detection of the key cardiac biomarkers. And for example, the results of CTN and the dimer, this test must get the result in 20 minutes after blood collection. Thank you very much. 刚才Jacopo 教授也问了我一下关于咱们在中国啊，我们这个刚才意大利的一些情况，让我介绍一下中国的情况。那么接下来呢，我想再请问Jacopo 教授，像您那里的这个分级诊疗是如何落地实施的？那么怎么能有效的来进行这个分流？另外我们也想知道，在意大利的急诊的这种实践中，像心肌标志物的检测时间是有明确限定的吗？像对于一些像偏远或者基层医院，我们是怎么来保证我们这肌酐蛋白结果的这个检测结果的一个精准和高效？Okay, I would like to ask Professor Jacopo, and how your tiered healthcare system is implemented in practice, and how effective patient triage is achieved. Additionally, in Italian emergency practice, are there explicit time limits for detecting cardiac biomarker for remote or primary care hospitals, and how to ensure the accuracy and efficiency of CTN results? Thank you.
Thank you for this question, Professor Zhang. In Italy, the hierarchical diagnosis and treatment system is mainly ensured through very tight regional coordination. Primary care hospitals manage low-risk patients, while tertiary centers receive only high-risk referrals, with structured referral pathways and remote specialist support. Regarding the cardiac biomarkers, there is no single mandatory national time window. However, this is a common habit for our hospital to consider the start, so short turnaround time of 1 hour. In tertiary emergency department, however, high sensitivity cardiac troponin testing is generally targeted well below this 1 hour rule, so often within 30 minutes, in line with the ESC chest pain center standards, while more flexible timelines, indeed up to 1 hour, can be accepted in remote or primary hospital, where the sample often needs to be transported. In these settings, accuracy and efficiency are ensured through portable or near-patient testing, centralized quality control program. So we have the opportunity of controlling all the instruments by remote, and even better and even more important, mandatory periodic staff training. High sensitivity, whole blood and point of care like platforms are therefore welcomed as key tools to support timely decision making without increasing the organizational burden.
感谢雅口教授啊，我们也是受到您这个思路的启发。既然我们已经围绕像我们中国和意大利我们两个国家的，像我们这个肌酐蛋白的一个检测现状啊，也进行了充分的交流。那么最后我还想向您请教一个关于未来的问题。那么全血信息标志物检测的优势呢，已经在急诊领域中显现出来了。那么如果展望未来呢？您认为下一个最具全血检测的这种潜力的应用场景是什么呢？Thank you, Professor Jacopo. Inspired by your perspective, since we have already fully discussed the current situation in China and in Italy, and I would like to conclude by asking you a final question about the future. The advantages of the whole blood cardiac biomarker. This testing have already become evident in the field of emergency medicine. Looking ahead, Professor Jacopo, in your opinion, what is the next most promising application scenario for the whole blood testing? Thank you.
Thank you for this insightful question that gives me the opportunity to share my personal vision of laboratory medicine, even beyond the cardiac biomarkers testing. So beyond emergency medicine, I believe that the next most promising application for whole blood testing lies in time-critical, resource-constrained clinical scenarios, and particularly within highly centralized healthcare systems, such as those increasingly and unfortunately adopted in Italy. In these settings, compact whole blood platforms may allow urgent algorithm-driven testing close to the patient, while avoiding duplication of laboratory infrastructure and unnecessary use of human resources, which is a key organizational priority for our laboratories. Looking ahead, a very promising field for whole blood testing can be bloodstream infection diagnostics. These may include both direct pathogen-related approaches and equally important, the host response to infections such as cytokines and other well-established or to be established biomarkers of sepsis. Whole blood testing is particularly well suited here because it supports rapid assessment, minimal pre-analytical handling, and repeated measurements, which may be essential for early recognition and monitoring of systemic infections, and also for proper antibiotic stewardship. In this context, it would be particularly valuable to implement these measurements on point-of-care platforms and or near point-of-care platforms, enabling very early assessment with minimal pre-analytical handling and the possibility of repeated measurements, which are nowadays essential for the timely recognition and monitoring of systemic infections.
Thank you for your answer, Professor Jacopo. And we have benefited greatly from it. And next, I will make the final summary in Chinese. Thanks again. 刚才Jacopo 教授的那个报告啊，也清晰地表明了我们对于全血心肌标志物的检测结果，也确实给我们展现出来了非常高的一个准确性和临床价值。那么给我们在这种对国内的这种对于这个全血的检测技术也提供了一个信心。尽管确实是我们中意两国在临床实践中，我们刚才也看到了，我们确实是每个国家有。我们两个国家有不同的特点啊，我们每个国家有自己的一个国情的一个特点。那么，但是我们对于全血心肌标志物的价值，这种共识是达成了一致的。我们认为呢，这个它不光是技术的进步，而且我们也意识到，这个时间就是心机。那么呢，对于急性冠脉综合征像这类的急征啊，每1分钟它的延误都可能会影响患者的预后。那么 全血检测呢，它能够凭借这种免离心快速周转这些优势呢，能够让临床决策呢更早的落地，也能够为挽救心肌呢争取宝贵的时间。所以现在呢，我们也知道这个快速检测对于全血检测它的一个快速检测的优势也是越来越凸显。那么未来呢，全血心肌标志物的检测呢，也将会继续推动心血管疾病它的这管理呢，能够向更高效、更精准的方向发展。通过打通像院内的临床科室、门急诊的检验，还有中心实验室的这种多场景互认，它最后的这1公里通过打通这最后1公里呢，我们不仅可以避免这种重复检验，降低患者的一个就医成本，最终呢，我们还能够真正实现是以患者为中心的一个高效诊疗。最后呢，让我们也非常感谢刘教授和雅克鹏教授，也感谢人脉呢为我们搭建了这场跨越国界的一个学术对话，让中意两国的临床经验还有技术探索能够得以碰撞交融。那么本次呢全血心肌标志物的性能验证与中意临床应用对话的线上授课也到此结束非常感谢大家，我们期待下次再见。Thank you very much, Jacopo.
Thank you for this very insightful discussion, and thank you all again for this opportunity to share also at thousands of kilometers of distance our experience and the evaluation of the instruments that we conducted with great pleasure.
Okay, thank you. See you later.
See you. Bye.
Bye-bye.